A very good afternoon to everybody. And I'm very much with great humility and gratitude. I thank the organizers for providing me the wonderful opportunity to be presenting before such a distinguished audience. So, for the next few minutes, as a renal pathologist, I'll be driving you through how to diagnose rejection in ABO incompatible cases on renal biopsy. So, as we know, long back it was considered to be a contraindication, but with better developed desensitization protocols, these ABO incompatible transplants are now in better use. And our job is to diagnose accurately on renal biopsy and pick up such crucial cases of rejection so that patient can be treated better. So the basic difference between the ABO compatible and incompatible cases lies in the antibody specificity. ABO compatible ones majorly are the implicating bodies are the anti-HLA antibodies, whereas in ABO incompatible we have the anti-A and anti-B antibodies. So this is the flow diagram showing the mechanism. Like we have the natural antibodies, that is anti-A and anti-B. And these then attacked the antigens, we all know, which are located, the A and B antigens. These are located on the endothelium. This endothelium, which is lining the vascular endothelium or tubular epithelium, and these antigens can also be present on the glomeruli. So as a result of this antigen antibody interaction, there is complement activation with a resultant vascular injury, giving rise to microhemorrhages and microthrombosis. So based on this mechanism, we can have three possible outcomes. Supposing the complement system is fully activated, switch on mode, then the case may go into hyperacute or acute rejection, which is a critical stage. If there is a complete halt, the biopsy may show features of accommodation, which I'll be discussing further. And then there is a third scenario in which there is an incomplete inhibition of complements. So in this scenario, what happens is, even though some degree of complement activation is present, even though cell lysis was not there, but some degree of endothelial activation will be present, and hence the transplant can go into chronic ABMR. So most of the cases which we see even practically, the cases of rejection in cases of ABO incompatible, they fall under category 2. That is the antibody mediated rejection and microvascular injury, better known as MVI. And fewer cases fall into the cellular rejection. Category 2 is further divided into various other groups depending on the chronicity, whether active, chronic, and so on. So majorly, like essentially the bottom line is there are not much differences in the histology in the ABO compatible and the incompatible cases. And in these cases also, they are characterized by the cardinal features of microvascular injury and so others also. Like for example, the better known terms of glomerulitis, as we can see here, the neutrophils infiltrating the glomerular capillary loops, which can be better appreciated in here in the Jones stain. Also, then we have the cardinal findings of peritubular capillaritis. And again, in chronic cases, the biopsy may show features of transplant glomerulopathy. That is, here we can see nice contouring or splitting of the glomerular basement membranes, which is better highlighted on the silver stain. And in few cases, we can also get features of thrombotic microangiopathy. Like here, we have a tuft which is showing this fibrinoid necrosis, which is better highlighted on the Mason's trichrome stain as fusionophilic deposits. And similar changes can be seen even in the blood vessels also as the fibrinoid necrosis of the vessel wall. So while reading, I came across this finding that it is a very uncommon finding, but we can find this, that at times IgM can also be found to be deposited in the peritubular capillaries in cases of ABO incompatible cases. And another finding is that of a neutrophilic pericapillaritis. That is, instead of lymphocytes, we have abundance of neutrophils in the peritubular capillaries. So based on the clinical scenario, the graft may either show hyperacute or acute rejection. And in case of hyperacute rejection, we well know that the kidney grossly will become swollen up, mottled, and cyanotic in appearance. And it may show grossly also, it can show areas of cortical necrosis. However, on microscopy, we have like lots of injury which is acute, and it will be represented in the form of massive interstitial hemorrhage, areas of interstitial edema, and then the glomeruli will be congested and they will also show some degree of necrosis. C4D staining will be positive. Then we can get areas of cortical necrosis. In cases of acute ABMR, again the kidney will be swollen and edematous like previously. And on biopsy, we get the findings of glomerulitis. Here also, we can appreciate these neutrophils. And when we take the help of IHC, then we find these inflammatory cells can be highlighted by CD3, indicating the lymphocytes, and CD68, that is highlighting the macrophages. So this indicates our glomerular injury. Then the other findings which we can get is glomerular or tubular necrosis. And again, we can have interstitial hemorrhage. And this is a characteristic finding again that at times we can get the collection of neutrophils in the lumen, not of PTC I've already told, but this collection of neutrophils we get in the tubules. So here, in this image, we can confuse such a scenario with that of a acute pyelonephritis because neutrophils are present in the tubules. So if suppose I have to explain by a case, so we have a young male who was on triple immunosuppression, case of ABO incompatible, and he had graft dysfunction. The biopsy here, as we can see here, shows some foci of glomerulitis, and we also have this peritubular capillaritis. Then mild interstitial inflammation, and C4T was positive in a diffuse manner. So what should be our interpretation in this case? Of course, it's a clear-cut case of active ABMR because of the reason that the biopsy shows features of microvascular injury and along with C4D positivity. So nothing complex in that, it's a clear-cut case of ABMR. And in such cases, we have to correlate with DSA and other serology and clinical parameters. Now in contrast, we have a second case. Again, a young male and day 10 biopsy of ABO incompatible. So here we can see that the biopsy more or less appears largely unremarkable. There is no evidence of MVI or injury whatsoever. And again, the C4D is showing diffuse positivity. So now what should be our interpretation in such a case? Should we call it as probable ABMR or no evidence of rejection or accommodation? So this is a scenario of accommodation. Why? Because there is no injury, but C4D is diffusely present. So in the clinical setting of ABO incompatible transplant, in such a scenario, the biopsy will represent the findings of graft accommodation. And so we should straight away not jump to giving anti-rejection therapy in such cases. Rather, we should monitor the renal function and follow up the patient. So coming to this fascinating phenomenon of accommodation, what happens is that even though they are circulating antibodies, the graft still functions normally, it survives, and the biopsy will not show any features of injury. And we can say that in a way, accommodation is just a manner of kidney tolerating. It is a tolerance of antibody binding, but without any injury. So it's basically, to summarize, it's a footprint of complement activation. And again, when we followed these ABO incompatible cases, the protocol biopsies up till 1 year, studies have shown that these cases have higher incidence of transplant glomerulopathy as compared to the ABO compatible ones. So a recent study also tells us what they did was they studied C4T expression in peritubular capillaries, but in those cases where microvascular inflammation was present, and these biopsies were for cause biopsies. So what they found, they divided the cases into three groups of C4D negative, focal positive, and diffuse positive. So by this table, I just want to show that the cases which had diffuse positivity for C4D, they also showed higher MVI scores, or vice versa, like higher MVI correlated with diffuse C4D positivity. In contrast, however, these higher C4D score patients, they showed lesser degree of chronicity, as can be seen here by lower CI and CT scores. And the reason probably could be because these cases had lower or lesser post-transplant time till biopsy. So the biopsy period was less, and hence the scarring was also less. But however, MVI was more. And this study then also cited various previous studies of Kuzi and Ishihara et al., and all of them came to the similar conclusion that C4D positivity, if present in conjunction with features of injury or features of rejection on histology, then it could be a predictor of adverse or poor outcome in cases of ABO incompatible cases. Then there is a role of, what is the role of molecular assessment basically? So all this molecular transcripts are currently under study only. They are being validated. A lot of studies going on recently. But this study from KI here shows what they did was they just compared uh, the C4D positive and negative cases in ABO compatible and non compatible patients, but they did not find anything significant. So it is a practical challenge for all of us alike that C4D interpretation should not be done in isolation. We need to rely strongly on the histology and also on the clinical data so as to avoid any overdiagnosis of ABMR and overtreat the patient. And fewer cases may also show T cell mediated rejection, but histology is mainly similar to that what we see in ABO compatible cases. Like we have interstitial inflammation, we have tubulitis, that is tubules infiltrating the lymphocytes infiltrating the tubular epithelium, and we can also get lesions of endotheliitis, that is leukocytes infiltrating the vessel wall and the also in the lumen. So TCMR is more or less similar to that in compatible ABO compatible cases. And the study has already been shown previously by Narayan sir. What I want to highlight in the study, when we compared the histopathology of ABO compatible and non-compatible cases, there was not much of a difference in the BAM scoring. The scores were equivalent. The only difference which was found out was that the ABO compatible cases showed a slightly higher degree of interstitial inflammation. But apart from that, the BAM scores were comparable. So, with this, I conclude with my key messages today that the histology of rejection in ABO incompatible transplants is essentially the same as in compatible ones. And C40 positivity is very common. We see it very frequently in our practice also. And it represents accommodation and not rejection. And for an accurate diagnosis, pathologists must be overcautious and we should take everything into account: the histology, serology, and the clinical scenario.